It's okay. Hi, good morning. There's only so many of us, so I'll just start. I'm Dr. Anusha Ajwani, and I'm Director and Consultant at Ajwani Eye Hospital, Bhopal. And today I'll be speaking about OptiWave refractive analysis. Let's learn a little something about a new gadget. It's new in the market right now. So what is basically OptiWave refractive analysis? It is an intraoperative aberrometry device which calculates the IOL power on the basis of lower order aberrations. It provides the cataract surgeon the ability to measure, refine, and verify outcomes during the actual surgical procedure, taking cataract surgery to an entirely new level. It uses intraoperative wavefront aberrometry, providing real-time refractive information to increase the precision and accuracy of IOL selection and positioning. However, it cannot predict the results with 100% certainty. It allows the surgeon to accurately predict the surgical outcome. Coming to its principle, the device projects light onto the retina and the reflected images pass through the optimal system of the eye, distorting its wavefront, which is subsequently analyzed according to optical and mathematical principles proprietary to the device. Instead of a laser light, Aura uses a superluminescent light emitting diode, that is SLED, and tableau Moir interferometer to take 40 measurements in less than 1 minute. The tableau Moir fringe patterns are produced by the reflected wavefront after it passes through two gratings placed at specific distance and angle to each other. The resulting fringe patterns provide information about the spherical, cylindrical, and axis components of the refractive error. It analyzes and combines data from the central 4 mm optical zone with a dynamic range of -5 to +20 diopters and an accuracy of ±0.3 diopters. It takes into account parameters such as posterior corneal astigmatism and high order aberrations, allowing the surgeon to confirm or revise the IOL power chosen according to preoperative biometry. So how does it work? It is attached to the surgical microscope with a display adjacent to it. It provides continuous streaming measurements of the IOL calculations intraoperatively and ensures proper IOL placement and determines treatment zones for correcting astigmatism. It assesses the refractive impact of lens options during implantation, provides convenient visual guidance for precise toric IOL rotation, and provides real-time verification that the toric IOL is positioned correctly. After phacoemulsification, irrigation, and aspiration, chamber is formed with visco-cohesive viscoelastic to increase the IOP up to 25 mm Hg. Cornea is washed and Aura is performed in aphakic mode in topical anesthesia. The patient has to look in the target green light and then Aura can be captured. There are settings which are available for post-LASIK and post-RK patients and can be selected as required. For toric IOL, Aura can be captured in pseudophakic mode and it suggests the rotation required, which can be used to check the correct astigmatism. It measures the total ocular refraction, including posterior corneal astigmatism and surgically induced astigmatism. Aura Analyzer database can identify outliers mid-procedure to help surgeon hit refractive targets with more precision and consistency. Coming to its uses, it is mostly used in IOL power calculation in normal, small, and longer eyes with equal or superior results compared to standard IOL power calculation methods. It can measure the refractive power in different meridians and is uniquely suited for toric IOLs. It is able to combine anterior and posterior corneal power along with the toricity of the implanted IOL within the capsular bag, improving the accuracy of IOL selection. It helps surgeons to choose the meridian and length of corneal relaxing incisions when correcting astigmatism. Technology is especially useful for patients who have undergone previous LASIK or RK surgery, or those who choose a premium IOL implant, or those with high astigmatism. In these patients, predicting the outcomes of cataract surgery can be difficult, and with Aura system, the mystery is now gone. Coming to its limitations, the fact that measurements taken during surgery do not reflect the post-operative state of the eye can introduce inaccuracies in IOL power calculation. The myometry of the eye can be affected at the time of surgery by patient factors such as squeezing of the eye, equipment factors, or intraoperative manipulations such as stromal hydration. These factors can change IOP and axial length, corneal thickness, and the refractive index of the anterior chamber. Certain conditions may also make it difficult to obtain the accurate readings, such as progressive retinal pathology, which can interfere with patient fixation, corneal pathologies such as Fuchs, keratoconus, advanced pterygium, which impair the cornea. Apart from that, visually significant media opacities such as prominent floaters or asteroid will either limit or prohibit the measurement process. Use of iris hooks during image capture will yield inaccurate measurements, and surgeons should be cautious while using aura on RK patients. The validations and accuracy of its usage in previous RK patients has not been studied well. In post-RK patients, the incisions could swell up acutely during the surgery, and the cornea shape and curvature at a pressure of 21 mm Hg just prior to the aura reading may be artificially changed, far away from preoperative measurements, and because of this acute change, it is also possible to have subsequent changes. To conclude, in the current era, where there is very low tolerance to suboptimal refractive errors, aura may serve as a guide to ensure correct IOL power correction and perform a much more custom refractive cataract surgery. Aura has been found to be successful in difficult situations such as prior keratorefractive surgery, where conventional biometry may result in under or overcorrection. Optical methods have been identified as the gold standard for IOL power calculation, but there is always scope of improvement. Thank you. Thank you, ma'am.
Shall we call the next speaker, please? Dr. Akash Shah, Dr. S. Chandra Devi, Dr. Anita Mishra. So I call upon Dr. Anita Mishra to give a talk on setting up low visual clinic in tertiary eye care center.
Good morning, everyone. My topic is very basic, but I think it's the need of the hour. We are very fortunate to be at Dehradun because India has been a pioneer in as being the National Institute for Empowerment of Persons with Visual Disabilities, which was established way back in 1967 for the empowerment, training for the blind, production of braille literature, aids and appliances for the visually handicapped. But unfortunately, I couldn't find the state-wise breakup of the total number of people who are having low vision, who are blind. What is the exact statistics as to the low vision services available, what are in use, and what are not in use. So at present, the service delivery model in India is scattered and unavailable in most states. And where it is available, it is not well coordinated. It may be hospital-based, school-based, NGO, or independent. But we know that it is the need of the hour because 25 to 30% of our cases are having either low vision or blindness who need either a simple device or some means of rehabilitation to have a better life. So how do we go about it? First, we take the history of the patient for the cause of the low vision, the onset, the present status, and then we decide upon the treatment, whether it is optical, medical, surgical, or laser. If we don't have these resources, we may refer the patient to a higher center, or we may treat it at our place. And of course, most important is the counseling part for the patient as well as the family. Now, after identification of the patient, we go about this following protocol. We do a clinical assessment. then functional and educational needs of the patient, interventions tailor-made and according to the needs of the patient, training for that, and follow-up. For that, we need a teamwork of clinicians, ophthalmologists, optometrists, rehab personnel, and educators, and others for administration. What are the equipments we need are the diagnostic and refractive sets, vision assessment tools, functional vision assessment tools, other optical aids such as magnifiers, non-optical aids, and other interventions. So in diagnostic tools for vision, we can do with the Snellen's chart, but it's better if we have the Logmar chart, that too with single letter optotypes. Pediatric visual acuity chart from pre-verbal children to school-going children, as well as the Taylor acuity, Lea symbol, all these should be in our armamentarium, and near vision charts in Logmar, and we should have a typoscope for better vision. Now, refraction is the most important part of this assessment. It is required for achieving the best corrected visual acuity for the purpose of certification for low vision or blind. Not only that, this BCVA helps us to predict the type of low vision device needed for the distance and near. And in refraction, retinoscopy is far more important than subjective. We should do monocular as well as the binocular assessment. And in central scotoma, use of prisms. So after doing the refraction, we should do a functional vision assessment, contrast sensitivity, and color vision. Then after calculating the BCVA, we suggest the type of devices we need, optical, non-optical, or electronic. In optical devices for distance, we can have monocular or binocular telescope according to the eye need of the patient. In near aids, we can have high plus power magnifying spectacles, handheld magnifiers, stand magnifiers, and telescopes. Non-optical devices are not the less important. We can have visors, table lamp, big font telephones, writing guide, note text, or the talking devices, devices which increase or decrease the contrast and illumination, and for totally blind patients, smart cane with audio and tactile guides. These will not enhance the vision of the patient, but they can definitely help in living a better life and for vocational training. Assistive devices are gaining very much importance nowadays because of the advent of these Android and other smartphones, which are very cheap and readily available for all patients. And they incorporate the high-tech methods like video magnification, changing the contrast, talking guides, computer hardware and software like JAWS and Magic, which are very much user-friendly, and all the patients can be trained with it. So a low vision clinic need not be very high-tech. We can devise new methods like the use of the mobile phone they are already having. We need to give much chair time to the patient and the parents for counseling and to letting them know their rights and all the avenues available. So the low vision clinic should provide appropriate, affordable, and accessible service intended to integrate a person with vision loss into the community by either enhancing the residual vision or doing something to improve with non-optical device. Service delivery to those with low vision should be aimed towards community integration of the low vision people by establishing low vision clinics at least in the tertiary care centers, which are the referral centers, and they should have a holistic approach, not only the optical devices, but also the overall rehabilitation of the patient and the parents and integrating them into the community, and which has to be done in a phased manner. Thank you for your patient hearing.
Hello? Do you provide this at subsidized rate at your center?
Ma'am, according to the government guidelines, there should be, this is a basic right for education up to 14 years of age. So all children can be integrated in the other schools for an inclusive education, and the government will provide free devices, either optical or non-optical, to these patients.
Okay.
But of course, the NGOs and other private clinics, they do charge. It is up to the patient if they can afford, or they can come to the government hospitals, especially the RIOs and the tertiary care hospitals. So they can write to the government for provision of devices.
Okay, thanks a lot.
Thank you, ma'am.
Thank you, Dr. Anita. Can we call the next speaker, please? Dr. Parul Sharma. Dr. Gazela Bruce Swardry. Dr. Marlene Benzi. Dr. Sarita Agarwal. So I call Dr. Sarita Agarwal to present pediatric refractive error, when and how to prescribe the glasses.
Good morning, everyone. Good morning, panelists. So I will be presenting on pediatric refractive error, when and how to prescribe the glasses. So the contents of my topics are e-metropization, then about the pediatric refraction, spectacle power prescription, and what are the various guidelines regarding the childhood refraction. So the process of e-metropization induces emetropia, that is no refractive error. So it occurs during postnatal development when the refractive component and the axial length of eye comes into equilibrium. The neonates are usually hypermetropic and with minimal astigmatism. So what is the refractive status of the children? So if that's a healthy neonates, these are usually hypermetrope, and at the age of 3 to 5 years, length of globe increases, say 5 millimeters from birth to 3 years. And in adolescent, the childs are mostly emetropic, but if you talk about, there is more myopia than hypermetropia. So in premature newborns, if the birth weight is less than 2,500 grams, these children are usually myopic and sometimes up to -10 diopters of myopia. So at the age of 3 to 5 years, again, there will be a refraction power. And suppose at the age of 5 to 6 years, the child is myopic, so that will be myopia at the later age. And if the child is more than 1.5 diopters hypermetropia at the age of 5 to 6 years, then that child is usually hypermetrope at the age of 13 to 14 years. So prescribing glasses for children, that is always a challenge because of the limited cooperation, then low reliability in vision assessment, and there is always a risk of amblyopia. All the children should undergo vision assessment at least once before the child starts going to the school. And early refraction is indicated in symptomatic cases, like if the parents are complaining of watching television or mobiles very closely. The gold standard in pediatric refraction is definitely a good retinoscopy. But before doing good retinoscopy, you will be very cautious while prescribing cycloplegic drops. Means if you are prescribing atropine, that may cause speech disorder or urinary retention. And it's sometimes contraindicated in cerebral palsy and epilepsy. If you are prescribing cyclopentolate, it may cause dermatitis and follicular conjunctivitis, and it may exaggerate seizures in epilepsy. And if you are dealing with children with neurological deficit, overdose may produce hallucinogenic effects. So how you have to prescribe the spectacle power? So in case of myopia, if you undercorrect it, that might lead to exotropia. And if you overcorrect it, it might lead to esotropia. So you have to be very cautious while dealing such children. So when to consider and what to prescribe, say if the child is, during the first year, if the child is having myopia of less than -5, definitely you have to prescribe the glasses, but reduce the power by 2, undercorrect it, because definitely there is some emetropization occur for the myopes also. And if there is less than -2 diopters of myopia, from 1 year onwards, so reduce it by 0.5 and 1 diopters. And if there is school-age myopia, you have to prescribe the full correction. If you're dealing with hypermetropia, and if you undercorrect the hypermetropia, that will lead to esotropia. And if you try to overcorrect it, it might lead to exotropia. So whenever, now, in hypermetropia, how will you deal it? So if the child is less than 3 years of age and having hypermetropia more than 2.5 diopters, partial correction is done. And if the child is 3 to 4 years age and the hypermetropic power are more than 3.5 or 4 diopters, definitely partial correction is done and you can subtract it 1 to 2 diopters. And in school-age children, full correction is given. And what if you are dealing with astigmatism? So if the child is more than 1.5 years or more than 2 years, and if the astigmatism is more than 2 or 2.5, again decrease the cylinder by 1 diopters up to 3 to 4 years of age. And in school-age children, again you have to prescribe the full cylinder. In cases of anisometropia, and if anisometropia is there with amblyopia, again correct full anisometropia and astigmatism, but correct hypermetropia and myopia as per the age. And after 3.5 years, you have to prescribe it fully. If no amblyopia, there should be strict monitoring. So when there is a risk of amblyopia, or what are the children in which there is a risk of amblyopia and you have to prescribe the glasses for sure. So if the child is hypermetropia at the age of 1 year, more than 4 diopters, or at the age of 2 years, if the hypermetropia is more than 3.5, you have to prescribe the glasses, otherwise there will be a risk of amblyopia. And if myopia is more than -1 or astigmatism is more than 1.5, again you have to prescribe the glasses, otherwise it will lead to amblyopia. So there are certain number of guidelines that have been published for refractive prescriptions by various associations in pediatric age group, like American Associations for Pediatric Ophthalmology and American Optometric Association. And recently, All India Ophthalmological Society has published guidelines for prescription of glasses in infants and young children. So these are the various guidelines, and these are the IGO guidelines, means what should be the power when you have to prescribe the glasses, otherwise that will lead to amblyopia. So what should be the prescription in special situation, means if the child is having exotropia, so any refractive error resulting in reduced vision should be corrected to improve the vision. Even the minor amount of myopia should also be corrected, and if there is astigmatism, then full correction is given. In cases of esotropia, full cycloplegic correction is given. In myopia, again give full correction. So why should we stop progression? Because there is always a risk of development of certain diseases like cataract, glaucoma, degenerative retinal diseases, and parents have to bear the cost of optical correction, and definitely for cosmetic purposes. So take-home message, 80% of the children accepts full prescription at first attempt, and if the child is not wearing the glasses in spite of sincere attempts, the parents for 4 months undercorrect the glasses, then prescribe the glasses. And first follow-up should be at the age of 6 to 8 weeks after prescribing the glasses, and occlusion should be given next visit. Thank you.
Can I have 2 questions? So what is your experience with these myopia control lenses?
Yes. So whenever the children, I am dealing with the children, means whenever they come to my OPD, if there is myopia, and if the child is, say, less than 2 years of age, then I usually undercorrect it, means, say, if the child is having more than -5 diopters, I usually, at first visit, I usually undercorrect it so that child can adapt the glasses. And after he's school going, I prescribe full correction. And in cases of hypermetropia, definitely, if the child is, say, 1 to 2 years, definitely I'll undercorrect it. First, I'll let the child to accept the glasses, then I'll correct it fully. And if there, definitely if there is esotropia, then we have to prescribe the full glasses.
No, no, madam. My question is about
progressive, this thing.
no. My question is about these. There are companies coming out with myopia control lenses,
Yes.
like a Stellest, and there is MyoSmart. Do you have any experience of those lenses?
Oh, no, no.
You are not.
No.
To stop progression of
Progression of
myopia.
Okay. Actually, I usually give atropine eye drops, but I have no experience with those
these
lenses. Sorry.
And there are these many softwares which are coming to control amblyopia.
See, actually, I'm working in a medical college as head of the department, so patients are usually non-affordable. So,
Okay, madam.
thank you so much.
Okay, I have a question. One second. How do you refrain them from mobiles?
Sorry?
How do you refrain the children from mobiles?
Okay.
Mobile
Okay.
uses.
Okay. So what I advise to the parents, if you don't use the mobile, the kids will also not use the mobile. So that is the first thing which I tell the parents. You have to be apart from the mobile, then only, and if the child, suppose in cases of amblyopia, definitely I advise the use of mobiles at least for 1 hour by occluding other eye. So he's busy playing games and amblyopia can be corrected.
Okay, this will be in the amblyopic children. Those who are using and getting the refractive error, no need to.
No, no, definitely we have to follow certain rules. Like we have to teach the parents about the mobile, means how it could harm
Basically, it is the counseling of the parents.
Yes, yes, definitely, a
If
counseling of the
if
parents.
the children don't see their parents using that,
Yes, definitely. That is the first advice I give to my patients.
same we do. Same we do.
Thank you.
Thank you, Dr. Sarita. May I call upon Dr. Jatinder Singh Balla for ELP concepts and practical applications.
Thank you, everyone. The topic I'm going to cover is effective lens position, the concept and the practical application of this concept. See, in earlier times, cataract was removed first and spectacle prescription given last. Today, we calculate the power of IOL first and cataract surgery is done afterwards. So, IOL calculation plays a very important role to determine the refractive outcomes after the surgery. Today, we can customize the power of IOL to achieve near plano results even in highly myopic or hyperopic eyes. But there are a group of patients we all know that who value their emetropia so much that they are ready to pay any amount to achieve it. And after surgery, if you break news to them that they require spectacles after cataract surgery, they are extremely disappointed. So what are the major sources of prediction error for IOL power calculation? ELP prediction accounts for 35%, followed by other parameters like axial length and keratometric measurements. So effective lens position is the most challenging part in IOL power calculation. And one of the goals today is to come up with the algorithms that help you to achieve near emetropia. See, in human eye is a dual eye system. In any dual lens system, if the primary lens and the distance of screen are fixed, which in eye it is fixed, cornea is fixed position, and axial length is fixed, then the effective power of the system will depend on the power and position of the second lens. In human eye, in phakic, it is crystalline lens, but in pseudophakic eye, it is the power and position of the second lens, that is IOL. So imagine, what all we want is IOL should sit right in the center of the capsular bag, but it does not always do so. Now this actual IOL power is 21 diopter, but IOL is sitting much anteriorly in the capsular bag, so effective IOL power will be much more, that is 22 diopter. And if it is sitting posteriorly, effective lens power will be reduced, 21 becomes 20 diopter. Why it happens? Because preoperatively anterior chamber depth is different from the post-operative anterior chamber depth. This is because lens, crystalline lens, which is about 4 or 4.5 millimeter, is replaced by a lens which is less than 1 millimeter. So the anterior chamber depth changes, and that's why effective lens power, effective lens position of the IOL also changes. In 1950, when the first IOL was implanted by Harold Ridley, it had a refractive surprise of nearly 20 diopters. So let's go to the history of effective lens position. Initially, the term effective lens position was used by Holliday in 95 to describe the position of IOL inside the eye, and it was thought that the effective lens position is equal to anterior chamber depth. And so the first value which was used was 4.5 millimeter, then subsequently it was increased to 5.25 millimeter. There are some hurdles in accurate estimation of effective lens position because the older formulae, they worked on these assumptions. That is, shorter eyes and flatter K eyes were supposed to have shallow anterior chamber and shorter effective lens position, in contrast to longer eyes and steeper K eyes, which are supposed to have deeper anterior chamber and longer effective lens position. But Holliday told us that there are 9 types of eyes. Eyes with normal anterior segment, 80% have shorter axial length and 90% have longer axial length. Similarly, in eyes with normal axial length, 2% may have shorter anterior segment and 2% may have longer anterior segment. So the relationship between anterior segment and axial length is not proportionate in 80% of short and 90% of longer eyes. So older formulae are bound to fall in short and long eyes. The initial formulae, they worked on basically 2 parameters, axial length and keratometry. But we all know 2 eyes with same axial length and same keratometry may require completely different IOL powers. This is due to difference between actual and predicted effective lens position. This was study published in JCRS, which was done by Holliday on 34,000 eyes, and they calculated the relative importance of various variables affecting IOL position, and in their study, axial length was found to be the most important factor, followed by other anatomical parameters. So let's classify the factors which affect effective lens position. There are anatomical factors, which I've already elaborated upon. There are surgical factors, which include size of CCC. IOL-related factors are also important: shape, length, flexibility, anterior regulation, then material of the haptic. So various formulas have various constants to take into account these which affect the effective lens position. SRKT, the older formula, had A constant. Haigis has A0, A1, A2. Hoffer Q and Holliday 2 have anterior chamber depth. Holliday 1 has surgeon factor, Olson has C constant, and Barrett has lens factor. What exactly is A constant? A constant is specific constant for each IOL, and value of anterior chamber depth is calculated by regression, and it is in the value of anterior chamber depth is incorporated into A constant, so indirectly it affects effective lens position. Optical method definitely measures it 0.2 millimeter deeper than the ultrasound methods. So factors affecting IOL constant are type of biometry used, axial length keratometry, IOL types, and surgeon factor. We all know about these theoretical and regression formulas. So the newer formulas, which are slowly replacing the older formulas, are Hoffer H5, LADAS, Olson, Barrett K, Hill RBF, Kane, and many other new factors. The third generation formulae, they calculated effective lens position is equal to distance from the cornea to iris plane plus surgeon factor. ELP is dependent on the anatomical factors, but surgeon factor is based on the regression studies based on retrospective BAL calculations using different IOLs. Holliday 2 used 7 factors to calculate effective lens position, in contrast to the older formulas, which are dependent on just 2, 3, or 4 factors. And these factors are not only axial length keratometry, but also anterior chamber depth, lens thickness, white to white, age of the patient, and previous refraction. There are mathematical methods available to interchange or intercalculate effective lens position depending on anterior chamber depth, surgeon factor, and A constant. Barrett Universal 2 formula, which has become most popular, it has effective lens position dependent on lens factor, which is then calculated by keratometry, axial length, anterior chamber depth, lens thickness, and white to white measurement. Hill RBF depends on artificial intelligence. Now if we compare Barrett and Hill RBF, both are current formulas, both are more sophisticated, and surprisingly both use different theoretical premises, but both give you reading which is within 0.25 diopter of each other. So what should I do? Should I use multiple formulas and then average the results? Douglas Koch uses this premise, but Holliday and Barrett says use specific formulas for specific situation instead of averaging. What is the role of intraoperative aberrometry? Intraoperative aberrometry, there is no accuracy limit of preoperative measurements, and it eliminates variability of various calculations and assumptions like refractive indices. Ray tracing, the ray tracing it uses different corneal refractive index. Now we are stuck at 90% accuracy within 0.5 diopter. We are not able to achieve accuracy more than this. Why? The limit is not the formula anymore. Limit is the least count. Precision limit for least count for keratometry is 0.25 diopter, axial length is 0.1 diopter. So these errors limit keep us at 90% accuracy. Can we achieve 99%? Yes, if we use newer formulas and use specific formulas for different situation. So these are various formulas where effective lens position can be calculated by these mathematical measures, but there are error in effective lens position in post-keratorefractive surgery patients. I will not go into detail. There is a role of ELP in multifocal IOLs, toric IOLs. So this is ELP square sheet, which if we have done mathematics in earlier times, you used to have quadratic equation ax square plus bx plus c, where x is calculated as minus b plus minus under root b square minus 4ac by 2a. So here you can actually calculate effective lens position if you are really interested. These are the accuracy limit of various formulas. You will find the most accurate formula. This is a study which is published in Clinical Ophthalmology in 2020. The older formulas in the first 5 are nowhere in the picture. The new formulas which are most accurate in shorter axial length, longer axial length, and medium range between 22 to 26 millimeter are Kane, EVO, VRFG, Barrett Universal 2, and Hill RBF. And nowhere are Haigis, Holiday, and SRKT are in the picture. So improvements in technology have allowed accuracy of biometry to double every 5 to 10 years. And by taking into consideration the individual ocular anatomy and converting values for effective lens position to the appropriate units, we can improve our accuracy level. So accurate estimation of effective lens position is the final frontier in accurate IOL power calculation, and newer formulas can help us achieve this. Just like in life, in cataract surgery also effective position matters. If same IOL power is placed more anteriorly, it behaves as a stronger lens. If same IOL power is placed in a more posterior position, it behaves as a weaker lens. Thank you everyone for your kind and patient hearing.
Thank you, sir, for that wonderful talk. Any questions?
Good morning, sir.
Yeah.
Fantastic presentation, sir. Just in normal cases, not abnormal anatomy, what is, how are you approaching to get this effective lens position in your practice? Any practical tips for that in your practice?
Yeah. In average eyes, all formulae will give you good results in average eyes. Problem occurs only in eyes with, in shorter eyes, less than 21 millimeter, which gives you maximum error. In longer eyes also, even Holiday will do well, SRKT will do well, but slowly and steadily I have shifted to just one formula, and that is Barrett Universal 2. You can also do Kane. All these formulas are free and available on the net. Just take your values, open Barrett Universal 2 or Kane formula, feed the values, and you get the IOL power. So there's no need to buy expensive equipments like IOL Master and everything just for IOL power calculation. Take your values, feed in, and you'll get the results. Problem occurs if you suddenly find there are some red flags, like axial length is long, but anterior chamber depth is less than average. That is eye which will give you error, because normally what we assume is longer eyes will have longer anterior chamber depth and shorter eyes will have shorter anterior chamber depth. But if there is a mismatch, you are bound to have errors. So better is use Barrett Universal 2 or other Kane formula and feed in, you can feed in lens thickness and anterior chamber depth also. It will improve your accuracy.
What are the factors of the lens, what you are considering exactly? Which lens, what it will give the result? You have mentioned about the lens also. Which lens you are putting? So exactly
No, you have to just fill the A constant of that. Depending on whether it is ultrasound method or optical biometry, just fill in that. And Barrett assumes, this newer formula assumes you are doing optical biometry. So you have to be careful about what A constant value you are using. I use either optical biometry, and at some places if I don't have, I use immersion method. Immersion ultrasound gives you quite accurate results. So no need to feel bad about using ultrasound if you are using immersion. Applanation biometry, it's out. But if you are using immersion ultrasound, it will give you equally good results.
Thank you, sir.
It was very elaborative presentation. Yeah. Thank you, sir.
Thank you, sir. There were a few speakers not present in the initial part. Are they here? Dr. Akash Shah, Dr. Chandra Devi, Dr. Parul Sharma, Dr. Gazila, Dr. Merlin Benzi. Okay, so we come to the end of this session. Thank you all. Please.
Yes, sir. Yes, sir. Why not? I forgot.